In the next section, we'll cover human immunodeficiency virus infection. Human immunodeficiency virus, or HIV infection, is a global pandemic affecting millions. HIV is a retrovirus that causes immunosuppression. The viral infection causes the person to be susceptible to infections that would normally be controlled through immune responses. The term HIV is used interchangeably with HIV infection. Since the beginning of the epidemic, sub-Saharan Africa has been the most devastated, but the Caribbean, Asia, Eastern Europe, and South America also have growing epidemics. In the past 30 years, important advances have been made in HIV prevention, testing, and treatment. With advances in treatment, HIV is managed as a chronic disease as people are living longer, resulting in a dramatic drop in the death rate attributable to HIV. In developed countries, the result has been decreases in the number of HIV-related deaths, improved quality of life, and a significant decrease in the number of children born with HIV. More than 1 million people are currently living with HIV in the United States, with an estimated 56,000 to 60,000 new infections occurring annually. In North America, the prevalence of HIV has been highest among men who have sex with men, but women, people of color, people who live in poverty, and adolescents continue and contribute an expanding proportion of new HIV infections. For the most part, HIV remains a disease of marginalized individuals, those who are disenfranchised by virtue of gender, race, sexual orientation, poverty, drug use, or lack of access to health care. AO is a 20-year-old Hispanic male college student who comes to the student health center complaining of pain on urination. His urine test is positive for Neisseria gonorrhea. What should you do? You should talk about treatment options for the gonorrhea and obtain a complete health and social history, including drug and sexual practices. HIV can only be transmitted under specific conditions that allow contact with infected body fluids, including blood, semen, vaginal secretions, and breast milk. In developing countries, the major route of transmission is heterosexual sex, and women and children bear a large part of the burden of the illness. The most common mode of HIV transmission is unprotected sexual contact with an HIV-infected partner. Sexual activity involves contact with semen, vaginal secretions, and/or blood, all of which have lymphocytes that may contain HIV. During any form of sexual intercourse, anal, vaginal, or oral, the risk of infection is greater for the partner who receives the semen, although infection can also be transmitted to the inserting partner. This occurs because the receiver has prolonged contact with infected fluids and helps explain why it's easier to infect women than men during heterosexual intercourse. Sexual activities that cause trauma to local tissues can increase the risk of transmission. In addition, the presence of genital lesions from other sexually transmitted diseases such as herpes or syphilis significantly increase the likelihood of transmission. HIV can be transmitted during exposure to blood through drug-using equipment. Used equipment may be contaminated with HIV and other blood-borne organisms, and sharing that equipment can result in disease transmission. In North America, transfusion of infected blood and blood products has caused only 1% of adult AIDS cases. Routine screening of blood donors to identify at-risk individuals and testing donated blood for the presence of HIV have improved the safety of the blood supply. The risk of infection after a needle stick exposure to HIV-infected blood is 0.3 to 0.4%, or 3 out of 1,000. The risk is higher if the exposure involves blood from a patient with a high level of circulating HIV, a deep puncture wound, a needle with a hollow bore and visible blood, a device used for venous or arterial access, or a patient who dies within 60 days. Splash exposures of blood on skin with an open lesion present some risk, but it is lower than that from a puncture wound. And healthcare workers have a low risk of acquiring HIV at work, even after a needle stick injury. Perinatal transmission can occur from an HIV-infected mother to her infant. Fortunately, the risk of transmission can be reduced to less than 2% in settings where pregnant women are routinely tested for HIV infection and, if found to be infected, treated with antiretroviral therapy, or ART. HIV-infected individuals can transmit HIV to others within a few days after becoming infected. Transmission of HIV is subject to the same requirements as other microorganisms, that is, a large enough amount of the virus must enter the body of a susceptible host. Variables that influence whether infection will be established after an exposure include the duration and frequency of contact with the organism, volume, virulence, and concentration of the organism, and host immune status. Initial infection with HIV results in viremia, large amount of virus in the blood. The concentration of the virus is an important variable. Large amounts of HIV can be found in blood, and to a lesser extent in the semen during the first 6 months of infection, and again during the later stages of the disease. Although unprotected sexual intercourse or blood exposure to an infected individual during these periods is more risky, HIV can be transmitted during all phases of the disease. The modes of transmission of HIV are not casual. It is not spread through casual contact. It is also not spread by tears, saliva, urine, emesis, sputum, feces, sweat, respiratory droplets, or the enteric route. AO informs you that he has been sexually active since age 15 with both males and females. He states he is always the on-top partner, meaning the inserting partner. He has had intercourse with 3 people in the last month and does not use protection. What should you do next? Well, if you haven't recommended it already, further testing for other sexually transmitted infections, including HIV, is in order. Inform him that testing is the only way to determine if he has contracted HIV. Negative results can relieve anxiety about past behaviors and provide opportunities for prevention teaching. Positive results can provide an impetus to seek treatment and protect his sex partners. Talk with him about ways to protect himself and others from sexually transmitting diseases, such as abstinence, non-contact sex, and using barriers. HIV uses chemokine receptors CXCR4 and CCR4 as co-receptors. CD4 is the main receptor to support binding and entry into the CD4 T cell. HIV is an RNA virus which replicates by using its RNA as a template to produce DNA, which is then integrated into the human genome. Immune dysfunction in HIV infection is caused by damage and destruction of CD4 T cells, also known as T helper cells or CD4 T lymphocytes. Like all viruses, HIV cannot replicate unless it's inside a living cell. HIV is surrounded by an envelope made up of proteins, including GP120, and contains a core of viral RNA and proteins. HIV has GP120 glycoproteins that attach to CD4 and chemokine CXCR4 and CCR5 receptors on the surface of the CD4 T cells. This is fusion. Viral RNA then enters the cell, produces viral DNA in the presence of the reverse transcriptase, and incorporates itself into the human genome in the presence of integrase, causing permanent cellular infection and the reproduction of new virons. There are two consequences of this action. First, because all genetic material is replicated during cell division, all daughter cells will be infected. And second, viral DNA in the genome will direct the cell to make new HIV. New viral RNA develops initially in long strands that are cut in the presence of protease and leave the cell through a budding process that ultimately contributes to cellular destruction. Initial infection with HIV that results in viremia lasts a few weeks. During the time of low viral load, which may last for more than 10 years, clinical symptoms can be limited. Even without symptoms, HIV replication occurs at a rapid and constant rate in the blood and lymph tissues. A major consequence of rapid replication is that errors can occur in the copying process, causing mutations that can contribute to resistance to antiretroviral therapy and limit treatment options. In the initial stages of HIV infection, B cells and T cells respond and function normally. B cells make HIV-specific antibodies that are effective in reducing viral loads in the blood. Activated T cells mount a cellular immune response to viruses trapped in the lymph nodes. Immune dysfunction in HIV disease is caused predominantly by damage to and destruction to CD4 T cells, also called T helper cells or CD4 lymphocytes. These cells are targeted because they have more CD4 receptors on their surfaces than other CD4 receptor-bearing cells. CD4 T cells play a key role in the immune system's ability to recognize and defend against pathogens. Adults without immune dysfunction normally have 800 to 1200 CD4 T cells per microliter of blood. The normal lifespan of a CD4 T cell is about 100 days, but HIV-infected CD4 T cells will die after an average of only 2 days. HIV destroys about 1 billion CD4 T cells every day. The body is able to produce new CD4 T cells to replace the destroyed cells for many years. However, eventually, the ability of HIV to destroy CD4 T cells exceeds the body's ability to replace the cells. Generally, the immune system will remain healthy with more than 500 CD4 T cells per microliter. Severe problems begin to develop with fewer than 200 CD4 T cells. With HIV, a point is eventually reached where so many CD4 T cells have been destroyed that there are not enough left to regulate immune responses. The major concern related to immune suppression is the development of opportunistic diseases, which are infections and cancers that occur in immunosuppressed patients that can lead to disability, disease, and death. This display is the typical course of untreated HIV infection. It is important to remember that disease progression is highly individualized, that treatment can significantly alter this pattern, and that an individual's prognosis is unpredictable. The information depicted in this figure represents data from large groups of people and should not be used to predict an individual's prognosis. HIV infections are divided into different stages, including acute, asymptomatic, symptomatic, and AIDS. In acute HIV infection, seroconversion, which is when HIV-specific antibodies develop, is often accompanied by a mononucleosis-like syndrome that may be mistaken for the flu. These symptoms generally occur 2 to 4 weeks after the initial infection and last for 1 to 2 weeks, although some symptoms may persist for several months. Some people also have neurologic complications such as aseptic meningitis, peripheral neuropathy, facial palsy, or Guillain-Barré syndrome. During this time, a high viral load, the amount of HIV circulating in the blood, is noted, and CD4 T cells counts fall temporarily but quickly return to baseline or near baseline levels. Many people, including healthcare providers, Mistake acute HIV symptoms for a bad case of the flu. Asymptomatic infection is the interval between untreated HIV infection and a diagnosis of AIDS. During this time, CD4 T cell counts remain above 500 cells per microliter, which is normal or only slightly decreased, and the viral load in the blood will be low. Because people are often unaware of their disease status, they have little reason to seek treatment or make behavior changes that could improve the quality or length of their lives and can unknowingly transmit HIV to others. Symptomatic infection occurs when the CD4 T cell count drops to 200 to 500 and the viral load increases. Symptoms seen in earlier phases become worse, leading to persistent fever, frequent drenching night sweats, chronic diarrhea, recurrent headaches, and fatigue severe enough to interrupt normal routines. Other problems, including infections, lymphadenopathy, and nervous system manifestations, may occur. The most common infection associated with the symptomatic infection phase of HIV infection is oropharyngeal candidiasis or thrush. Candida rarely causes problems in healthy adults, but is more common in HIV-infected people. Other infections that can occur at the time include shingles, caused by the varicella-zoster virus, persistent vaginal candidal infections, outbreaks of oral or genital herpes, and bacterial infections. Malignant vascular lesions such as Kaposi sarcoma lesions can appear anywhere on the skin surface or on internal organs. Kaposi sarcoma is caused by human herpes virus 8. Lesions vary in size from pinpoint to very large and may appear in a variety of shades. Oral hairy leukoplakia, an Epstein-Barr virus infection that causes painless white raised lesions on the lateral aspect of the tongue, can occur at this phase of the infection and is also an indicator of disease progression. A diagnosis of AIDS cannot be made until the HIV-infected person meets criteria established by the CDC. AIDS is characterized by severe immune system suppression and CD4 T cell counts less than 200 cells per microliter, an opportunistic infection, an opportunistic cancer, wasting syndrome of loss of 10% or more of ideal body mass, or AIDS dementia. Opportunistic infections or diseases generally do not occur in the presence of an functioning immune system. Pneumocystis jirovecii is the type of pneumonia that can appear as an opportunistic disease associated with HIV infection. AO tells you he drinks at weekend parties and has smoked pot but not recently. He reports no regular use of injection drugs, tobacco, or anabolic steroids, but that sometimes he gets so drunk he doesn't remember. How would you rate his risk and why? Well, AO is at high risk for contracting another sexually transmitted infection and or HIV because of his active sexual life with multiple partners, direct contact sex with same-sex partners, inability to recall possible exposure when under the influence, unprotected sex, and history of a sexually transmitted illness. Clinical manifestations and complications are listed in Table 1510. Organisms that do not cause severe disease in people with functioning immune systems can cause debilitating, disseminated, and life-threatening infections during this stage. Several opportunistic diseases may occur at the same time, further compounding the difficulties of diagnosis and treatment. Advances in HIV treatment have decreased occurrences of opportunistic diseases. Diagnosis of HIV infection is made by testing for HIV antibodies and/or antigen in the blood. The most useful screening tests for HIV are those that detect HIV-specific antibodies. The major problem with these tests is that there is a median delay of 4 weeks after infection before antibodies can be detected. This creates a window period during which an infected individual may not test positive for HIV antibodies. Rapid HIV antibody tests provide results in 20 minutes and are recommended by the CDC. A standard antibody test done on blood or oral fluid specimens and tested by a laboratory provide results from a day to a week later. Rapid testing is highly reliable and provides immediate feedback to patients who can then be counseled about treatment and prevention. This is an important advantage because many people do not return to get their test results when the longer time requiring tests are used. Positive antibody tests should be confirmed by another test, usually the Western blot. See Table 1511 on HIV antibody test screening processes. The progression of HIV infection is monitored by 2 important laboratory assessments: CD4 T cell counts and HIV viral load. CD4 normal range is 800 to 1200 cells per microliter. In HIV, viral loads are reported as real numbers, 1,260 copies, or as undetectable. Undetectable indicates the viral load is lower than the test is able to report. Undetectable does not mean that the virus has been eliminated from the body or that the individual can no longer transmit HIV to others. Abnormal blood test results are common in HIV infection and may be caused by HIV, opportunistic diseases, or complications of therapy. Decreased white cell counts, below normal numbers of lymphocytes and neutrophils, low platelet counts, and anemia are often seen. Altered liver function caused by HIV infection, drug therapy, or co-infection with the hepatitis virus is common. Early identification of co-infection with hepatitis B or C virus is extremely important because these infections have a more serious course in patients with HIV and may ultimately limit options for ART. They can cause liver-related mortality and morbidity as well. There are 2 types of resistance tests that can determine if a patient's HIV is resistant to the drugs used in ART: the genotype assay and the phenotype assay. The genotype assay detects drug-resistant viral mutations that are present in reverse transcriptase and protease genes. The phenotype assay measures the growth of HIV in various concentrations of antiretroviral drugs. Much like bacteria antibiotic sensitivity tests, these assays help to determine new drug combinations for patients who are not responding to therapy. Collaborative care of the HIV-infected patient focuses on monitoring HIV disease progression and immune function, initiating and monitoring antiretroviral therapy, preventing the development of opportunistic diseases, detecting and treating opportunistic diseases, and managing symptoms. It also includes preventing or decreasing complications of treatment and preventing further transmission of HIV. To accomplish these objectives, ongoing assessment, clinician-patient interactions, and patient teaching and support are required. Perform a complete history and physical exam. These findings will determine the patient's needs. This is also a good time to ensure that case reports required by the state and health department have been completed. Determine the need for referrals. Remember that a newly diagnosed patient may not be able to retain or understand information. Be prepared to repeat and clarify information over the course of several months. AO returns to the clinic 3 months later after refusing HIV testing or teaching. He is now concerned as one of his partners was just diagnosed with HIV. He wants help. What should you tell him about HIV testing? Well, it involves testing a blood sample or oral fluid for HIV-specific antibodies. It's important that you work together. Testing is the only way to determine if he has HIV. Early treatment and support is very important for his health. You'll provide him with information and support to help him understand and deal with this concern. You'd like to know more about his available support systems. You need to know when the last risk of exposure occurred. Teaching is important to help prevent further sexually transmitted infections. Tests need to be repeated at intervals of up to 3 months after each possible exposure. Let him know if rapid testing is available at your clinic. The results are usually available in 20 minutes, but it's more expensive than standard testing and should be verified with standard testing. It's important to protect himself and his partners from further risky behaviors during the 3-month interval until final results are available. Recommendations for starting therapy in the chronically infected patient are summarized in Table 1512. HIV cannot be cured, but ART can delay disease progression by decreasing viral replication. When taken consistently and correctly, ART can reduce viral load by 90 to 99%, which makes adherence to treatment regimens extremely important. The major advantage of using drugs from different classes is that combination therapy can inhibit viral replication in several different ways, making it more difficult for the virus to recover and decreasing the likelihood of drug resistance. A major problem with most drugs used in ART is that resistance develops rapidly when they are used alone or taken in inadequate doses. Thus, combinations of 3 or more should be used. Also, many ART drugs have dangerous and potentially lethal interactions with other commonly used drugs, including over-the-counter and herbal therapies. Management of HIV is complicated by many opportunistic diseases that can develop as the immune system deteriorates. Examples of opportunistic diseases include Pneumocystis jirovecii pneumonia, PCP. That's because it used to be called Pneumocystis carinii pneumonia. Mycobacterium avium complex, sometimes abbreviated MAC, and Kaposi sarcoma. Prevention is the preferred approach to opportunistic diseases. Adequate ART, vaccines like hepatitis B, influenza, or pneumococcal, and disease-specific prevention measures can be effective in delaying or preventing many opportunistic diseases associated with HIV. Although usually not possible to eradicate opportunistic diseases once they occur, prophylactic medications can significantly decrease morbidity and mortality rates. Advances in prevention, diagnosis, and the treatment of opportunistic diseases have contributed significantly to increased life expectancy. Since HIV infection can be prevented, nursing care for individuals not known to be infected with HIV should focus on preventing disease transmission. The first step is to assess the patient's individual risk behaviors, knowledge, and skills. Don't make assumptions about people or their behaviors. Assess for risky behavior on a regular basis because things can change. These questions provide the minimum information needed to initiate a risk assessment. A positive response to any of these questions should be followed by an in-depth exploration of issues related to the identified risk. Based on the assessment, nursing interventions can then encourage the patient to adopt safer, healthier, and less risky behaviors, particularly in regard to sexual intercourse, drug use, perinatal transmission, and work issues. Specific assessments are needed for an individual who's been diagnosed with HIV infection. Subjective and objective data should be obtained. Early recognition and treatment can slow the progression of HIV infection and prevent new infections. A complete history and thorough systems review can help identify and address problems in a timely manner. Nursing interventions can help the patient adhere to drug regimens, promote a healthy lifestyle that includes avoiding exposure to other sexually transmitted and blood-borne diseases, protect others from HIV, maintain or develop healthy and supportive relationships, maintain activities and productivity, explore spiritual issues, come to terms with issues related to disease, disability, and death, and cope with symptoms caused by HIV and its treatments. The complexity of HIV disease is related to its chronic nature. As with most chronic and infectious diseases, primary prevention and health promotion are the most effective health care strategies. Even with recent successes in HIV treatment, prevention is the only way to eventually control the epidemic. Health promotion encourages early detection of the disease so that if primary prevention has failed, early interventions can be initiated. Table 1514 presents a synopsis of nursing goals, assessment, and intervention at each stage of the HIV infection. Nursing interventions are based on and tailored to patient needs at every stage of the HIV disease and can be instrumental in improving the quality and quantity of the patient's life. Care plans are individualized and change as new treatment protocols are developed and/or as HIV disease progresses. The major drug classifications for HIV include entry fusion inhibitors, non-nucleoside reverse transcriptase inhibitors, nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors. Treatment regimens can be complex. The drugs have side effects and frequently interact with other medications. Current guidelines for starting ART are based upon the degree of immunosuppression as measured by the CD4 T cell count. You might see Table 1512. The problems that impede HIV vaccine and microbicide development are numerous. HIV lives inside cells where it can hide from circulating immune factors. HIV also mutates rapidly so that infected individuals develop HIV variants that may not respond to simple vaccines or microbicides. In addition, 2 strains of HIV, 1 and 2, cause infection, and at least 9 clades or subtypes of HIV can be found around the world. AO says he will not be abstinent but is willing to use a condom during contact sex. What are the main points you need to cover when teaching about barrier methods of protection? First, use only condoms made of latex or polyurethane. Second, store condoms in a cool, dry place, protect them from trauma, and don't use them past the expiration date. Third, use only water-soluble lubricants with condoms. Fourth, place the condom on an erect penis before any contact is made with the partner's mouth, vagina, or rectum. Fifth, hold the condom at the base of the penis and remove the penis and condom from the partner's body immediately after ejaculation. Sixth, dispose of the condom by removing it, wrapping it in tissue, and discarding it. And seventh, never reuse condoms. HIV infection is preventable. The goal is to develop safer, healthier, and less risky behaviors. These techniques can be divided into safe activities and risk-reducing activities. You need to be prepared to discuss sensitive topics including sexuality and drug use. Suggest a wide variety of activities to reduce the risk of HIV infection so individuals can choose methods that best fit their needs and circumstances and individual life patterns. Safe sexual activities eliminate the risk of exposure to HIV in semen and vaginal secretions. Abstinence is the most effective strategy. There are safe options for those who cannot or do not wish to abstain. Safe sexual activities include masturbation, mutual masturbation, and other activities that meet the no-contact requirements. Insertive sex between partners who are not infected with HIV and are not at risk of becoming infected with HIV is also considered to be safe. Risk-reducing sexual activities decrease the risk of contact with HIV through the use of barriers. Barriers should be used when engaging in insertive sexual activity, oral, vaginal, or anal, with a partner whose HIV status is not known or who is known to have HIV. The most commonly used barrier is the male condom. Efficacy means protection provided under ideal circumstances. Effectiveness means protection provided in real-life circumstances. Female condom effectiveness is 94 to 97% against HIV and other STIs. Dental dams are squares of latex used to cover external female genitalia during oral sex. Injecting equipment called the works includes needles, syringes, and cookers such as spoons or bottle caps used to mix the drug, cotton, and rinse water. Equipment used to snort or smoke drugs can also be contaminated with blood and should not be shared. Some communities have needle and syringe exchange programs that provide sterile equipment in exchange for used equipment. Studies show drug use does not increase, rates of HIV and other bloodborne infections are controlled, and an overall cost-benefit result in these communities. Cleaning equipment before use can also reduce risk by decreasing the chance of blood contact. Perinatal transmission can also be decreased. Women need to have information about family planning methods, HIV, HIV antibody testing, and ART if they're infected. Pregnant HIV-infected women need information about abortion, how to maintain the pregnancy, and using ART to decrease the risk of transmission. If HIV-infected pregnant women are appropriately treated during pregnancy, the rate of perinatal transmission can be decreased from 25% to less than 2%. ART has significantly decreased the risk for infants born to HIV-infected women, and more of these women are now becoming mothers. The risk of infection from occupational exposure to HIV is small but real. Should the nurse be exposed to HIV-infected fluids, post-exposure prophylaxis with combination ART can significantly decrease the risk of infection. The CDC recommends testing for all people regardless of the patient's risk or perceived risk. The CDC recommends an opt-out process in which the patient is given the opportunity to decline the test, but it is offered as routine. The goal is to normalize the test, decrease the stigma related to HIV testing, find hidden cases, get infected individuals into care, and prevent new cases of infection. As you talk to AO about barrier methods of protection, he begins to look away and seems to lose interest. He finally says, "I don't know if I can do this." What are some cultural considerations that may be a factor here? Well, Hispanic culture may influence an individual's acceptance of condoms. Condoms are not only protect an individual from disease, they also prevent conception. Contraception is problematic for many Hispanic cultures either because of religious prohibitions or the desire to have children. Hispanic men may also have been raised with the cultural concept of machismo, which supports the notion that men are in control. This may especially interfere with condom use in heterosexual encounters if condom use is seen as weak and not using condom is seen as a way to control the female partner. The nursing assessment in HIV disease should focus on early detection of symptoms, opportunistic diseases, and psychosocial problems. They will be confronted with complex treatment decisions, feelings of loss, anger, powerlessness, depression, and grief, social isolation, altered concepts of physical, social, emotional, and creative self, the possibility of death, and/or thoughts of suicide. Patients and their family members, friends, and caregivers must also deal with associated social stigma and discrimination. These factors can contribute to problems with adherence to treatment, a dangerous situation because of the high risk of developing drug resistance. Interventions you may provide include teaching about the advantages and disadvantages of new treatments, dangers of poor adherence to therapeutic regimens, how and when to take each drug, drug interactions to avoid, and side effects that must be reported to the healthcare provider. Guidelines on when and how to initiate ART are based on the degree of immune suppression. Table 1512 provides the recommendations for treatment. Issues to consider when selecting the initial drug regimen include the ability of the patient's HIV to resist specific drugs, potential medication side effects, existing comorbidities, and dosing schedules. This is a critical decision because the first treatment regimen is generally the patient's best chance for success. Adherence to drug regimens is critical to prevent disease progression, opportunistic disease, and viral drug resistance. The difficulty of adhering consistently to the drug regimen is probably clear to anyone who has tried to take a 10-day course of antibiotics. Patients in treatment for HIV infection must take at least one pill a day, but most take many more, and they must take those pills every day for the rest of their lives, even when uncomfortable side effects occur. Missing even a few doses can lead to drug resistance. See Table 1518 for strategies to improve adherence to ART, such as simplifying regimens, using reminders, and eliciting support. Supporting a healthy immune system can help delay HIV disease progression whether or not the patient chooses to use ART. Interventions include nutritional support to maintain lean body mass and ensure appropriate levels of vitamins and micronutrients, moderation or elimination of alcohol, tobacco, and drug use, keeping up to date with recommended vaccines, getting adequate rest and exercise, reducing stress, avoiding exposure to new infectious agents, accessing mental health counseling, getting involved in support groups and community activities, developing a consistent relationship with healthcare providers, including attendance at regular appointments, teach patients to recognize symptoms that may indicate disease progression and/or drug side effects so that prompt medical care can be initiated. See Table 1517 for symptoms that patients should report. AO tells you he really cares about one of his partners. What do you tell him about informing his previous sexual partners about his gonorrhea? What should he tell them about the HIV test if he tests positive? AO should be encouraged to inform his sexual partners about the gonorrhea diagnosis. He should also be told that gonorrhea is often asymptomatic in women, and his recent female sexual partners need to be tested and receive treatment, or they may develop infertility. His male partners may need to be diagnosed, treated, and counseled about transmitting the infection to others. Gonorrhea is a reportable disease, which means that the diagnosing clinician must report AO's case to the health department. Personnel at the health department have been trained to trace the sexual contacts of people with sexually transmitted infections and to tell them of the risk for infection. AO will be encouraged to provide the names of his recent sexual partners to health department personnel. Health department personnel can make disclosures anonymously, meaning the AO's name will not be used. HIV is also a reportable disease, and partner tracing and notification can be handled in a similar manner. If AO chooses to notify his partners himself, he should be provided with assistance and counseling on how to approach the discussion and how to prepare for his partner's reactions. Chronic diseases are characterized by acute exacerbations. Nursing care becomes more complex as the patient's immune system deteriorates and new problems arise to compound existing difficulties. The best way to prevent opportunistic diseases is to assure that the patient is adhering to effective ART regimen and taking prophylactic medications for opportunistic infections. Providing supportive care specific to the opportunistic disease, should it occur, is important nursing care. While HIV-infected patients share problems experienced by all individuals with chronic diseases, these problems are exacerbated by negative social constructs associated with HIV. Behaviors may be viewed as immoral, illegal, or reflect a lack of personal control. Even though illegal, according to the ADA, fear surrounding the transmittable nature of the disease can lead to pervasive stigma and discrimination. Physical problems related to HIV and/or its treatment can interrupt the patient's ability to maintain a desired lifestyle. Nursing interventions are similar to those for patients who do not have HIV. Some patients develop metabolic disorders with certain characteristics. It's not clear why these disorders develop, but it's probably from a combination of factors including long-term infection with HIV, side effects of ART, genetic predisposition, and chronic stress. Other characteristics include changes in body shape, fat deposits in the abdomen, upper back, and breasts, fat loss in arms, legs, and face. This may be due to lipodystrophy, which manifests in a buffalo hump, which is hypertrophy, and facial wasting. Management of these metabolic disorders focuses on early detection, symptom management, and helping patients cope with emerging problems and changing treatment regimens, especially to avoid potentially fatal complications. A frequent first intervention is to change ART medications because some drugs are more often associated with these disorders. 1 year later, AO returns to the clinic with a complaint of night sweats and a productive cough for a week. His CD4 lymphocyte count is 76. He's lost 13 pounds in the last month, and his record shows a history of a positive PPD. What do you think is happening? Well, he has an opportunistic infection and is likely HIV positive. Indications are it's Mycobacterium tuberculosis. Collectively, the night sweats, productive cough, weight loss, and history of positive tuberculin skin test result indicate this diagnosis. Despite new developments in the treatment of HIV infection, many patients eventually experience disease progression, disability, and death. Sometimes treatments do not work for the patient. Sometimes the patient's HIV becomes resistant to all available drug therapies. In other cases, the patient may make a decision to forego further treatment, allowing the disease to progress toward death. The number of persons over age 60 living with HIV is anticipated to grow. As a nurse, you need to be aware of the special health concerns of an HIV-infected older adult. They are susceptible to the same diseases, heart cancer, diabetes, bone disease, arthritis, hypertension, etc., as non-HIV infected older people, but they may experience them at an earlier age and may be at higher risk of comorbidities due to the effects of the medication used to treat HIV. Polypharmacy is a concern because the multiple medications older adults may have to take could have interactions or be potentiated by HIV medications. It may be difficult for the older adult to get appropriate health care and support if they are ashamed and hesitant to tell anyone that they have HIV. Let's do a few questions. A diagnosis of AIDS can be made for a patient with HIV with a CD4 T cell count less than 500, a white cell count less than 3,000, development of oral candidiasis, or the onset of Pneumocystis jirovecii pneumonia. The correct answer is D. The CDC has established criteria for a patient to be diagnosed with AIDS. AIDS is diagnosed when an HIV positive develops at least one of several criteria. Examples are CD4 T cell count less than 200 and a fungal infection such as Pneumocystis jirovecii. Candidiasis infection must be of the bronchi, trachea, lungs, or esophagus, not only the mouth. The nurse working in an HIV testing and treatment clinic plans teaching about antiretroviral therapy for which of the following? A patient who tested positive for HIV 3 years ago and has developed tuberculosis. A male healthcare worker who is HIV negative but has unprotected sex with men. Patient who was infected with HIV 10 years ago and has a CD4 T cell count of 650. Or a patient with persistent generalized lymphadenopathy who was exposed to HIV 2 years previously. The correct answer is A. Antiretroviral therapy initiation is recommended for the following patients infected with HIV: a history of AIDS-defining illness, such as tuberculosis, a CD4 T cell count of less than 200 cells, or between 200 and 350, pregnant women, persons with HIV-associated neuropathy, and persons co-infected with hepatitis B. The nurse is caring for a patient who is receiving antiretroviral therapy for treatment of AIDS. Which assessment best indicates that the patient's condition is improving? Decreased viral load, increased drug resistance, decreased CD4 T cell count, or increased aminotransferase levels? The correct answer is A. Goals of antiretroviral therapy in the treatment of a patient with HIV are to decrease the viral load and maintain or increase the CD4 T cell counts. Combination drugs are prescribed to prevent or decrease drug resistance. Some of these drugs may impair liver function. Increased aminotransferase levels indicate impaired liver function.